Fortunately, Dr. Cohen allowed me to introduce him today. As you all know, he's been here longer than me and longer than a lot of us. Is an icon in the world of infectious diseases and global health. An icon.
True.
It's hard to say anything more than that, except for sort of, you could call him the god of infectious diseases.
It's all
here at UNC. And he has a tight schedule. He has to leave at 1 o'clock, so he's starting.
Yes.
And I want to thank you for giving grand rounds.
Thank you. Well, I'm going to talk about things that I'm not Bill Grossman's talking. I'm going to talk right quick about prevention of HIV. And here the problem is, most of you have lived with this. Some of the older people in the audience have not had HIV as part of their life for their entire career, but the younger people, this has always been in the background. And it's worth just very briefly noting that this is a big epidemic with 16 million people who've died and at least 36 million people infected and about 15,000 new cases a day. It is not, does not exclude the United States. In the United States, this remains a fairly common disease, actually. In the United States, our demography is a little bit different still because of still the epidemic in the United States focuses on gay men. About 2/3 of the infections in the United States are in gay men. But there has been a real movement towards more women being infected, especially women of color. And there's a movement from urban areas to the southeastern United States. Ada Adamora, who's on our faculty, has really done remarkable work in trying to understand the kind of demography and movement of HIV in the United States. And the thing that's gotten most attention recently is that the CDC appears to have really dramatically underestimated the incidence and prevalence of HIV. So they were estimating about 40,000 new cases a year in the United States over the last 15 years, and they were trying, they claimed 15 years ago they were going to reduce the number of new cases to 20,000 a year. In fact, using tools that are not perfect but are better, it's now recognized there's about at least 56,000 new cases a year and probably about 1.2, 1.3 million with infection. Probably only 600,000 or less have been recognized, 800,000. So there's a lot of people with undetected HIV and there's a lot of new cases of HIV. And I think it's fair to recognize that this disease in the United States is really unequally distributed and visited on minorities, much higher in African Americans and Latinos, and it is obviously truly epidemic in gay men. It's been recognized in the congressional testimony last week that the HIV prevalence among African American men in some cities in the United States is higher than it is in some resource-constrained countries. And the argument was, how are we spending all this money in Botswana and Malawi when we could be spending more money in the United States on prevention activities? And I don't think anybody would argue that that's appropriate. So what I'm going to talk about for 45 minutes is our opportunities to prevent HIV infection. And we have 4 windows of opportunity. We can take unexposed people and try and prevent them from becoming exposed and risking getting HIV. We can try and prevent it, people at the moment of exposure. We can try and prevent infection after exposure, and we can try and do what I'm going to call secondary prevention when we get there. Most of the dollars that are spent, the NIH is spending about, I think, somewhere between $1 and $3 billion a year on AIDS prevention. No one's 100% sure what the number is. Most of the research dollars are spent on biological strategies of prevention. But what most of the kind of activity that focuses on keeping people who are unexposed from getting exposed. And that's a real difficult challenge. So here's the kind of thing we know about keeping people who are unexposed from getting exposed. First, we know that abstinence and total monogamy in a seronegative couple will work. So if you never have sex, you're not going to get HIV. But you also can't use drugs. You can't use IV drugs, and you can never have sex. If you do that, you will not get, and you can't have a blood transfusion in a developing country. Those are 3 strategies that will guarantee you to remain uninfected. Second, you can be in a partnership where you and your partner are reliably faithful to each other and know you're both seronegative at that moment in time, and you will not get HIV. Those are your strategies that are available. Obviously, this has not worked completely, although in some places it's helped. The second thing you can do to keep from getting infection is you can use barrier methods, and you have 2 barrier methods. You can wear a condom properly every single time you have sex. If you do that, you're very unlikely to get HIV. But the problem is this doesn't work in many developing countries because people want to have babies, and they know that the condom might interfere with having a baby. The second thing you can do as a barrier method is circumcision, which I'll talk about in more detail. I think it's safe to say that HIV prevalence has fallen in some communities worldwide, and at the end of this talk we'll come to what are called combination multi-level approaches. So circumcision prevents acquisition. And why might it do that? Well, you're replacing the mucosa with an epithelium. You're reducing the prevalence of ulcers, which facilitate HIV transmission. And in the mucosa that's no longer there, when you take off the foreskin, even an adult, what is otherwise a mucosa becomes thick skin. And it's not rocket science to see that this skin is not going to easily acquire HIV, and the number of receptive cells is lower. And but people didn't believe this. There was a lot of observational data that was compelling. People didn't believe it. So 3 randomized controlled trials were done comparing circumcised and uncircumcised men. These were not double-blinded. Obviously, you kind of know if you leave a surgeon's office and there's no foreskin anymore, it's pretty hard to mask that. It's not a sham operation. But these 3 studies all combined to show about 60 to 70% prevention of HIV acquisition when the circumcision was done. So circumcision is a really big deal in the HIV field, but is it really, it's hard to believe it's going to be sufficient as an HIV prevention tool, because first of all, there are people who don't want to do circumcision. Like, where is my foreskin is a big issue. If you're going to circumcise a child now to prevent HIV 20 years from now, they may say, well, what happened to my foreskin? And you're going to have to explain you took it off at birth in order to prevent a disease 20 years later. Second, Indians, which represent 1.5 billion people, they will not get circumcised because circumcision is common among Muslims living on the border of India, and there's no interest in that. Third, the Chinese are not very interested in circumcision because they have a real proclivity to one child. No, they're only allowed one child, and that one child is preferred to be a boy. And when the boy is born, they do everything to protect the boy, and they're not real interested in touching the penis of the newborn boy. So you have a lot of cultural barriers to massive circumcision. Having said that, in Africa, there are a lot of programs to roll out circumcision and use it as a tool both in children and adults to prevent HIV. Okay, so that's primary prevention, is keeping yourself and your patients negative. Secondary prevention is the moment of exposure. So UNC has done a lot of work on understanding what happens at the moment of exposure. And the transmission event Transmission event is governed by how infectious is the person with HIV and how susceptible is the person who does not have HIV. A lot of work has gone into understanding this. And we know pretty much for sure what's on this curve from a paper we wrote a few years ago, but it's been kind of observationally confirmed many, many times. When the concentration of HIV in the semen, which is or the female genital secretions, is very low, transmission events become improbable and fairly rare. As the concentration goes up higher and higher, and you can measure the concentration, and UNC helped to develop these measurements, when you measure the concentration, then at higher concentrations, the transmission probability goes up dramatically. This is not rocket science. Most infectious diseases are governed by a curve of inoculum, and the more the inoculum, the greater the transmission probability. The other thing we've learned is more complicated, and this is pretty interesting and it's not fully understood. When a patient with HIV, and let's make it a male patient, and the ejaculate is studied, and Jeff Anderson, who's in the Department of Medicine, is a big guy, raise your hand, Jeff. He studies HIV swarms and ejaculates, and that's a good thing. And so when the ejaculate is studied, the ejaculate contains a lot of different viral sequences, a swarm. There are hundreds, if not thousands, of different viruses in that swarm, like ant colonies. And then in the swarm, most of the viruses are defective in some way. They're abortive. They could not cause infection. But still, the swarm contains a lot of different variation. Turns out that the infections that occur have 2 unique features. First of all, they're all viruses. In the swarm, there are some viruses that want to use lymphocytes and some viruses want to use macrophages. But only the macrophage-loving viruses cause infection. 99% of the time, they're macrophage-loving. We're not sure if it's because they love macrophages or if the lymphocyte-loving viruses were eliminated. Second, 80% of the time, only one virus causes infection. So out of this huge swarm, one virus had some advantage that we don't understand. Sometimes there's up to 3 viruses, rarely more than 3 viruses. So that we can tell somebody's just been infected by the degree of viral variation. And so this is an important observation, and Jeff and Ron Swanstrom and others are working on this. Now, when you try and look at how common the transmission event is, it's not all that easy to do. Most times, if you're a medical student, you read a paper, it says HIV transmission takes 1,000 episodes of intercourse. Well, that's a lot of episodes of intercourse. Most people in the world have intercourse no more than 8 times a month, okay? And that's in, quote, young people. If we look at the people in this room, and don't raise your hand, no volunteers. There'll be no audience participation, although Andy I might pick on. But so if you, no data, data free. The point is many studies have been done that say young people have intercourse 8 times a month, and older people, let's say 40, 50, 60, have intercourse far less often. So it's not a realistic number to think it takes 1,000 episodes of intercourse are needed. So Kim Powers, who works with me, wrote an article last month that I think is really important, showing that acute transmission, that there are methodological problems that render this number not right. And by the way, we published this number ourselves 7 or 10 years ago. We published a paper with this number, and this is just not the right number. So if we look at Kim's paper, what it says is that, yeah, the number could be as low as 1 in 1,000 for vaginal intercourse, but it goes way, way up for anal intercourse, unprotected anal intercourse. It goes way, way up for sexually transmitted infection. It goes way, way up for uncircumcised people. So the point is the number is heterogeneous. And what we think really happens is shown on this slide, that a lot of HIV depends on what we're going to call amplified transmission. That while the number might be low if the viral inoculum in the genital secretions is low, if the genital secretions have a lot of virus, the transmission probability is going to be much, much higher. So during acute infection, so here's somebody, and we're going to talk a lot about acute infection in a few minutes. During acute infection, the inoculum is very high. You get 10 billion copies of HIV. And so with that much inoculum, the transmission probability becomes 20, like 1 in 20. So 20 episodes of intercourse are all you need to have an HIV transmission event. Then the inoculum drops as host defenses take over. And let's say the inoculum is very low. Well, then the transmission probability is very low. But suppose you decide you get gonorrhea or trichomonas. Well, then once again, the inoculum in your genital secretion goes up and you become more contagious again. Furthermore, you have a double whammy event. Gonorrhea is transmitted very efficiently. So first you would transmit gonorrhea to your partner. That partner now has an inflammatory process, so the HIV transmission event would be incredibly facilitated. So amplified transmission probably leads to a lot of cases of HIV transmission. It's estimated that maybe as many as 1/3 of all cases of HIV are transmitted in people with acute infection, and as another 1/3 are transmitted in people with AIDS who don't recognize they're infected, are sick, but are still sexually active. Now, one issue here that was on the preceding slide, I don't know if I can do previous, let me see if I can go back a slide. One issue here is the STDs. We are just about 100, there are 44,000 papers about STDs and HIV. And in those 44,000 papers, virtually 100% of them conclude STDs, classical STDs, help drive HIV. This should not be rocket science. But then when you try and do randomized controlled trials of treating STDs to prevent HIV, you don't succeed. In 7 trials that have been done, only 1 trial blocked HIV transmission. So this led people to say, well, maybe STDs are not important. This is not right. There's 2 conclusions. One is the 44,000 papers are wrong, or that to treat STDs and prevent HIV is very difficult. So to prevent HIV by treating STDs, you need to treat just the right STD at just the right point in time in just the right people with very effective drugs and for the right duration of time. And let me give you an example of a failure along these lines. So a giant $100 million study was done. That's hyperbole. A $30 million study was done. $38 million study was done called HPTN-039. And the hypothesis being tested was this. It said we're going to treat people with genital herpes who are not symptomatic, HSV2 antibody positive, who are HIV negative. We're going to give them acyclovir 500 milligrams twice a day, and we're going to prevent HIV acquisition. That study failed to prevent HIV acquisition. But what was shown after the study was that dose of acyclovir did not prevent herpes reactivation. So while ulcers were less common, the herpes was still growing, changing the biology of the host. So they were treating the right disease maybe, but without the right dose of a drug and maybe at not the right time. So enough said about that. STDs are important. So the second opportunity for prevention is this moment of exposure. And this is where HIV is not, it's all or none, okay? There is no patient who gets a little bit infected, okay? There used to be a belief that there were viral blips. That's gone. Everyone is either HIV positive or HIV negative. We can divide the species like that. And this is what happens. You are exposed to your inoculum, whether it's by blood or by general secretions. And then there is an eclipse phase where we can't see any virus. And in humans, that eclipse phase is really short. It's only 5, 6, 7 days. In animals, it might be a little bit longer, some animals. Then virus can be detected, and there's a thing called ramp-up viremia. And during ramp-up viremia, a bad thing happens. HIV would be curable except for this bad thing. During ramp-up viremia, the host forms a latent pool of HIV. The latent pool of HIV is distributed all over the body, and there are at least two components to the latent pool. A mystical component we don't understand, and another part of the latent pool where virus is integrated into the host DNA, so that unless you activate all the cells, all the lymphocytes of the body, you can't see the latent pool. David Margolis on the faculty here studies the latent pool. The key to curing AIDS is the latent pool. The scientist who understands how to eliminate all the viruses in the latent pool cures this disease. And this is now a very hot topic with the Gates Foundation supporting initiatives to cure AIDS focused on this latent pool. So the latent pool forms, and then you have irreversible infection, and then you have signs and symptoms, and then the virus falls for reasons we don't understand, and the virus falls to a set point. If your set point is high, you're going to go on to develop AIDS very quickly, and you're very contagious. And you're not going to know what your set point is unless you get a test and know you're HIV infected. If your set point is low, you're going to live a long time and be much less contagious, at least as far as we know. We don't understand all the things that control the set point. Genetics help control the set point, but there are other features as well. So, if our mission is this window of time, the problem is that is an unbelievably short window of time to interfere with you acquiring from HIV. So we have to have strategies that the species does not know how to do. I'll tell you an anecdote in a second. So one thing we could do is modify innate immunity. In your mucosal secretions, you have innate immune cells. If we knew how to modify innate immunity to eliminate HIV, we might be able to prevent HIV. We have no idea how to modify innate immunity. Second, we can make a vaccine. Third, we can use antiretroviral therapy. Let's talk about all three things. First, let's talk about vaccines. The strategy for vaccine is like this. What we'd like to do is know how to make neutralizing antibodies. So here's the ramp-up viremia, here's the set points in somebody who's not protected. Here's a person with the Runge vaccine. I'm going to name it after you, Marshall. The Runge vaccine, which is worth billions of dollars to the University of North Carolina, and would really make the department solvent if Runge made especially if a cardiologist made an HIV vaccine, it would be earth-shaking. So it would be like a sign of brilliance way beyond what we already anticipate. So the Runge vaccine would make broad neutralizing antibodies that would prevent HIV acquisition. But the problem with the Runge vaccine is we don't know how to make a vaccine that has an anamnestic response in 5 days. Okay, even if we had a vaccine, the amount of time is too short for an anamnestic response. And we don't know how to make a neutralizing antibody vaccine. So we gave up a few years ago. We're starting again recently, and instead we decided to work on cell-mediated immunity. And the idea there was, for a variety of reasons, we believed if we made T cells recognize HIV, that when you would not be protected from getting HIV, but when you got your HIV, your peak would be lower and your set point would be lower. If your peak was lower, theoretically, you would be less contagious to the next person. If your peak was lower, theoretically, your integrated pool would be smaller. If your peak was lower and your set point were lower, theoretically, you'd have a healthier life. So we made a whole bunch of these CTL vaccines. And this is a summary. We don't know how to make neutralizing antibodies. But in animals, if we gave the animals the CTL vaccines, this is from Norm Letvin's work, the blue is the animals that are vaccinated. They had a statistically reduced peak and a statistically reduced set point, and it all caught up after 143 days. But this animal trial led to the test of a vaccine called the Merck STEP trial. That vaccine failed unbelievably miserably. So it failed so badly, they stopped the trial and unblinded the trial, partly because more subjects got infected who got the vaccine than who didn't get the vaccine. So that Fred?
You know, looking at this and with the wisdom of Einstein, which I admit is unfair, that's very unimpressive data.
I didn't make...
It did fail, but if an ordinary person just looked at that...
They would think it wasn't worth...
That looks like a failure.
Okay, let me rephrase Fred's point. Fred's point is, first of all, the vaccine field, I would say, got a little bit lost. First of all, it stopped trying to prevent HIV. It completely stopped. It just tried to modify HIV. Second, it got waylaid by unimpressive data, exactly as you said. And so, wishful thinking. And because of this and this trial, there was a summit of all the wise people in the United States, not Obama and McCain, but everybody else was at the big summit. And at the big summit, Tony Fauci took a very dramatic step to stop forward movement of this whole class of vaccines. That's being reconsidered now, but he put an end to all these trials. So, but I do believe there's a new monkey trial that just happened with another CTL vaccine where the monkeys were theoretically protected by a guy named David Watkins. So the field's in no way dead, but it is where it is. Now, having said this, here's the bottom line if you're interested in HIV. We are going to continue to work on HIV vaccines no matter what. Okay? It doesn't matter how many setbacks there are. We have absolutely no choice but to make an HIV vaccine. If it takes 100 years or 200 years or 500 years, there's no option. And I don't think anyone at the NIH believes there is no option but to go forward. Along those lines, we are leaders in a thing called the CHAVI with Duke, Oxford, Alabama, and Harvard. And the CHAVI is the single biggest grant ever given, $381 million in one award. And we're in year 3 of a 7-year award. And the CHAVI has made a lot of observations that we think are going to help us to understand how to enable the development of a vaccine. But I think it would be wrong to make people believe that tomorrow we're going to make a vaccine. So if we can't make a vaccine, what else can we do immediately? Well, we can use antiretroviral agents, and there are 3 ways we can use them. Oops, let me see if I can, I'm very bad at this. There are 3 ways we can do this. And I thought... Click outside. Click outside? There's 3 ways we can use antiretroviral agents for prevention. We can use them as pre-exposure prophylaxis, as post-exposure prophylaxis, and as therapy. And I'm going to tell you real quickly about all 3 strategies. So for pre-exposure prophylaxis, this is a really important study. These 44 monkeys are worth $1 billion. And let me explain why. So what these guys did at the CDC, they took monkeys and they take an inoculum of SHIV and they put it in the monkey's rectum. And the control monkeys, who are shown here, the control monkeys, all of them get infected over time. And then, or all but one got infected over time. And then in monkeys that receive oral tenofovir, at first there was a belief that oral tenofovir as a pill, like this is a disco pill. I think I'm going to go out on a date, I'm going to get drunk and have sex. Well, these monkeys weren't thinking that. But the idea is that the monkeys were going to have their pre-exposure tenofovir. And at first there was a blush of enthusiasm because the monkeys seemed to be protected. But over time, these monkeys got infected. So then the monkeys were given supernormal doses of injectable FTC, and they were a little protected. Then they were given oral tenofovir plus FTC, and they were a little bit better protected. And then if you gave them really high doses of tenofovir and FTC, none of the monkeys got infected. These doses are supranormal. They would cause your kidneys to fail and your bones to fall apart. Nevertheless, this generated a lot. So, I mean, this would not be good for your health, okay, this dose of tenofovir and FTC. But nevertheless, these 44 monkeys generated 14 clinical trials. So ongoing in the world, shown by all these stars, are trials of tenofovir alone taken daily, trials of tenofovir and FTC taken daily, and I'll talk about microbicides in a second, a topical agent. So a lot of research is going on in this, and I think the general opinion is that these drugs are almost certainly going to work. So I could say with 90% assuredness that in your lifetime, in the next 5 years, there will be publications saying if you take tenofovir or Truvada daily, you will probably avoid getting HIV. The problem is daily. It's not sensible to take an HIV negative person who could use condoms. You know, do you really want to give your patient who's HIV negative Truvada every day? No. I mean, we give a lot of other pills. We give birth control pills every day. We give glucose. What's that stuff glucose lowering drugs? Buse is not here, but he gives them to otherwise healthy people. Buglitazole. Yeah, we do have other examples in medicine where we give otherwise healthy people drugs every day. And I think the thinking about daily Truvada is you would do it for adolescent women who are at very high risk in Africa, along with birth control pills, during a window of time where you tried to get them to be more responsible and less likely to acquire HIV. Now, there is another study there's a more recent study of pre-exposure prophylaxis of tenofovir and of Truvada, rectal exposure. All the animals get exposed, but these animals only get two doses of Truvada, and these animals are also protected even though they only get 2 doses. So there's a possibility that this stuff can work intermittently. So you'd go on a date, it would be a great date, and you would have, not a great date for you, Marshall, but a great date because you had unprotected intercourse and you took your Truvada before and your Truvada after, and you did not acquire HIV. There is a social feature of this. Does this inspire people to have unsafe sex? Does this inspire people to get other STDs? Does this inspire people, to do things they would otherwise not do? That's a component we won't talk about. We're going to limit ourselves today just to the biology. Now, Chris Patterson and Angela Gashuba and others, they've done studies with a drug called Maraviroc, which is a drug that blocks the CCR5 receptors you guys are familiar with. So Maraviroc is interesting because remember, 99% of the viruses that cause infection need to use the CCR5 receptor. What Chris and Angela showed in a paper that's coming out is that this stuff concentrates in the genital tract, and it stays around the genital tract for a very long time. So they gave a steady state dosing, and they could find it in the cervical vaginal fluid for 3 days at higher doses than in the blood plasma. So this leads me to want to make a new drug, Truvarac. So we would say that Gilead and Pfizer, those are the 2 companies, should work together to marry Truvada plus Maraviroc and make this new drug. And I believe A, they will make this drug, and I believe B, they will call the drug Truvarac. And I have patented the name Truvarac. So we'll see. They may not name it, but I made up this name, so I'm very proud of myself. Okay, the other thing you can do is use a topical agent. Now, the topical agents, you can use them anywhere in the life cycle, and I think this is trying to show you next slide. This is trying to show you all the different places. You got free virus, kind of binding, and we have these kind of non-specific stuff that's kind of like seaweed trying to block the binding, and that stuff's not proven very effective. And more recently, all these antiviral agents have been made into gels, and these antiviral gel agents can work at different phases of the life cycle. So a woman would have in her purse a gel, and she would use that gel before intercourse, and that gel would prevent her from getting HIV. There's a lot of enthusiasm. And so tenofovir gel is the farthest along. There's a lot of other gels. But I think what's more exciting are these cervical rings. So you can take the gel and put it in a cervical ring, and the ring sits on the cervix. And the ring, this is like the ID's alternative to a stint. And so the ring, bring it back to home. So I want to translate. Although it's not metal, it's latex. And so the ring leaches out antiviral drugs. You can also, by the way, put all kinds of computer chips in these rings. And so you could see like how many times a woman had intercourse, her geographic location. It's like a load jack. You think I'm kidding? I'm not kidding. These rings have computer chips, and while it's not widely discussed, you can know everything about your mate. You can know like miles walked a day. I mean, you would not believe. You think I'm kidding? I'm not. But you certainly can know if somebody leaves the city and about whether they had intercourse. And how many times they use the ring. So these rings, I think, are going to work. These gels are going to work. There's a study that was done. I think I might have another slide. Yeah. There's a study just done at the CDC unpublished. I'm trying to always give unpublished data wherever possible to make it more interesting. 1% tenofovir gel or 1% tenofovir FTC tested in a vaginal pigtail macaque, a little bit different macaque model. And it was there's a late breaker saying if you took this stuff and gave it to the animal 30 minutes before the animal had sex with the the animal didn't have sex, but the animal had exposure from the scientist, that these animals were protected. But exposure not to the scientist, help me, the exposure to the virus inoculated by the scientist through a syringe. If you did this 30 minutes before, the animals were protected. But interestingly, a paper is coming out that said that in these studies, 2 out of 8 animals had delayed onset of HIV transmission. That is, so there was like exposure, there was replication of HIV in the mucosa, and only 8 weeks later did the animal seroconvert. So this whole field could lead to some whole other kind of biology that we don't understand of kind of aborted, semi-aborted HIV transmission events. Okay, so at this point we've talked about the unexposed person, vaccine development and antiretroviral therapy, and I couldn't really be more enthusiastic about antiretroviral therapy. What about the emergency room after exposure? So now you're in the ER and somebody's been raped or believes they've been exposed. So here's the bottom line about that. First of all, we cannot do a clinical trial to prove that post-exposure prophylaxis works. It's not possible. And the reason it's not possible is because we don't know when you get raped, we don't know if the rapist was HIV positive or negative. You'd need huge numbers of subjects to even try and approach this problem. So post-exposure prophylaxis requires emergent usage of drugs and 28 days of therapy and usage of 3 agents. I need to clarify confusion. The US CDC has 2 sets of guidelines. One that I helped to write about non-occupational exposure, another set of guidelines about needle sticks. The needle stick guidelines are really stupid. They say if you're a little afraid of getting HIV, take a couple of drugs. If you're really afraid of getting HIV, take a whole bunch of drugs. That makes no sense. So the real guideline should say, if you know something about the virology in your community, the chance of a resistant virus, you would probably almost always take 3 drugs. And you would use the 3 drugs guided by your community, what you know about that community. You'd also be guided by pharmacology. You'd also, and the CDC gives you 3 days to start the drugs. It's really an emergency. In the monkey model, you could still get prevention over 3 days. In the mouse model, which a guy that was here yesterday talked about, you only get prevention for 1 day. So it's really an emergency. We like the pills are available in our clinic, in ID clinic. They're available in the emergency room. If there's a needle stick or an exposure, you give the woman or man the pills right then. Now, sometimes you want to talk about it, and you could talk about it days later. If somebody's been raped, the time to discuss whether they want to take post-exposure prophylaxis is not then. The time to talk about it is 3 or 4 days later when you can make a decision to stop the drugs for whatever reason, but don't miss the window of opportunity. And once you start the drugs and decide you're giving a course of therapy, you've got to do it for 28 days. The problem with post-exposure prophylaxis is the healthcare workers are really not confident that it works. And so there's a paper coming out in the journal STD that shows that in Canada, 98% of the people that were eligible, only 40% of people took the course of therapy. And that's because the healthcare workers aren't really into this. You know, they're ambivalent. So I think we have to get over that. Human failures have occurred. Moving this thing. Human failures have occurred mostly if the therapy is delayed and after anal intercourse. And enough said. Okay, the last thing to talk about before we're done today is about the treatment of the infected person. So this is a real big 900-pound gorilla. Because the way HIV started, our prevention programs have been kind of illogical. Let me give you a metaphor. Tuberculosis, we all manage tuberculosis patients. We don't worry about the kind of cycle. So I want to say this just right. Tuberculosis infected patient, they're upset that they have tuberculosis. And we say, we're going to put you in the hospital, give you some pills, we're going to render you less contagious, we're going to send you home. That's how we do it. We don't give everybody in the world a mask and say we don't want to hurt the feelings of the person with tuberculosis. Everyone should wear a mask forever, and that's the way to prevent tuberculosis. And I'm not saying that to attack HIV-infected people at all. The point is we started this epidemic with tons of stigma, houses being burned down, a lot of terrible things happening, no drugs, tons of, at one point 14% of the patients in this hospital were in the hospital for HIV. We had 5 deaths a week of HIV. So we've come through a lot of eras here. So our prevention programs have to evolve to match what's available. But our prevention programs have mostly focused on keeping everybody unexposed and have had a lot of trouble marrying treatment and prevention. So in the clinics, for example, the Ryan White money, which pays for our clinic, until 2 or 3 years ago, you were not allowed to spend any Ryan White dollars on prevention, which is crazy, because in the end of the day, we would be able to prevent a lot of infections if everyone knew their status and if people could be dealt with so that they became less contagious. So the first thing is about knowing your status. We estimate that about at least 60% of transmission events in the United States occur from people with established infection who've never been tested, who don't know their status. So the real incredible challenge to us is to get HIV testing done more broadly. Now here's another, how many of you have ever, I guess, how many, no, let me ask it the right way. Let me not, so I'm stuck. No, I don't want to ask your testing status. I want to say, how many of you have ever seen a rapid test? Raise your hand. How many have ever done a rapid test? Okay, so we developed a technology that's unbelievable. And that is, you do a finger, first of all, you can do it on the mouth oral swab, or you can do a finger stick, take 1 drop of blood, and in 11 minutes know your status, okay? It's an incredible technology. Now, if we had that for cholesterol and diabetes, there'd be people around the block waiting for their test. But people don't get HIV tested at anywhere near the rate that is appropriate to the actual risk in the population. In the U.S., maybe it's not appropriate to test everybody, although federal guidelines say everyone should be tested, especially younger people. But certainly in developing countries where a very small number of people have been tested, huge numbers of those tests should be done. So we've really failed to take an incredible technology and roll it out to use it properly. So the first issue is to get people tested. The second issue is to recognize that if you have a partner that you think is monogamous, and I don't want to ruin your marriage today, maybe they're not monogamous. So the safety, the being monogamous, being faithful, the thing we say is faithful, that's a big slogan. Being faithful can actually be fatal if you're faithful to a partner who themselves is HIV infected and doesn't know their status. Now, this is a huge deal in Africa where young women want to get pregnant. And so they marry, their husband doesn't know their status, the woman's trying to get pregnant, she acquires HIV at the same time she acquires pregnancy. So that is a huge, huge problem. So HIV testing is one key. The second key is kind of understanding this risk pyramid. We have the following pyramid. We have 2.5 million people who are on ART, and we're going to come back to that in a second. Does ART prevent HIV transmission? That's a really key question. Second, we have 30 million people who do not know their status. Okay, 30 million people infected. Of all the people HIV infected, 30 million of those people don't know they're HIV infected. So how are we ever going to do secondary prevention unless we create an environment where many more of those people know that they're HIV infected and acquire both the proper behavioral strategies and the proper biological strategies. Then among these 30,000 people, we have other little pyramids. We have people with AIDS who are more contagious. We have people with STDs. And then we have acute infection, which is what we study here a lot. The state of North Carolina is the only state in the country that automatically tells you whether you have acute infection. All public health tests done here tell you about acute infection as well, piloted by a lot of people on the faculty here. And these acutely infected people are very contagious for 8 weeks. But after 8 weeks, they're much less contagious. The couples issue is a big issue. Here's an example, and all over the world, people are very concerned about couples. Here's the Bushini district in Uganda. They go door to door. They measure hundreds of thousands. Now they're going with the rapid test in your house, and they're saying, we're going to test everybody in your household. They test hundreds of thousands of people. They come up with a lot of people who do not know their status down here. This is a fairly low percent for some countries, and then a lot of these people are in relationships that are discordant. So all these discordant relationships represent another opportunity for an HIV transmission event. So then the question is, we have 2 opportunities for HIV infected people. One opportunity is to encourage them to have safer sex behavior. Carol Golan is a real leader of strategies, behavioral strategies that are tested in our clinic here with CDC and NIH money to understand how you can encourage behavior change, safer sex behavior among HIV-infected patients. The other thing we could try and do is treat everybody. And this is a very popular idea. It is the idea you can treat your way out of the epidemic in the sense that if all 30 million people were on therapy and they were rendered non-contagious, maybe the epidemic would go away. And so there are the following issues. First, there is strong biological plausibility that treatment works. This is from one of our own studies. We measure HIV in semen before therapy. We measure HIV in semen after therapy. It's very hard to measure HIV in semen after the therapy, and the drugs concentrate in semen. So it's a real good idea to believe, or it's reasonable to believe that an HIV-infected person whose virus is suppressed in blood is likely also suppressed to some extent in the genital secretions and that is rendered less contagious. There are retrospective clinical studies that I won't go into in detail. There are 2 big observational studies, and in those 2 big observational studies, almost no HIV transmission events occurred when the person went on therapy. Like the expected cases didn't occur. And there are ecological studies. And the ecological studies are like, in Taiwan, they tested 39 million people. They found 4,000 people HIV infected. They treated all 4,000 people, and they estimated that they had reduced the expected incidence of HIV by 70%. So now this is where we are. But and the Swiss made a declaration. Actually, Pietro Vernazza, who worked with us here, went back to Switzerland, and they made a thing called the Swiss Declaration. And they said, look, we're tired of this. If your patient's on treatment and they're reliably suppressed, they're probably not contagious. Now, immediately the WHO and US CDC said, this is nuts. Don't tell your patient that. So there's a big fight about what you tell your patient who's on therapy. And they call this the Swiss Declaration. I think the UNC attitude is we think that therapy probably renders people less contagious, but we always want to do another clinical trial. So here's our clinical trial. So we have the world's biggest clinical trial, HPTN 052. It's a randomized clinical trial of 1,750 discordant couples in 9 countries. And the way this works is you take couples where the index case is infected and they're not, and they are willing to take therapy very early. So they would start their therapy with the CD4 count of 550. So they start very early therapy, and then you don't let their CD4 count fall below 250. So they're still sexually active with their partner. They're counseled, they're told not to be risky, but still they're sexually active. So you randomize to early versus delayed ART, and you examine, in 1,700 couples, you examine not the subject, you examine whether they've transmitted virus to their partner. And over 6 years, there ought to be enough power to see a 30% reduction in HIV transmission. The other thing you learn in this is how soon should you start HIV therapy. Right now, we still delay ART therapy. Many experts think this is nuts. You should just start therapy as soon as you find the infection. So this is being studied in the same trial. The drugs alone for this trial cost $27 million. The trial itself costs $100 million to do this for 7 years. And UNC is really leading this trial. Okay, so and leaving time for questions, I'm getting close to the end of this. Here's kind of the deal. For prevention of HIV, we've done a lot of different trials, 9 behavior change trials, 4 circumcision trials, 1 diaphragm trial, 9.5 microbicide trials, 1 PrEP trial that was just for safety, 7 STD trials, and 2 vaccine trials. Most of these have failed. The circumcision trial succeeded, and one of the 7 STD trials succeeded. But RCT, randomized controlled trial results, are only one measure of success, because we know in many communities in the world, HIV prevalence has gone down. So there have to be other things that have worked in those communities. And there are 15 randomized controlled trials in progress this year alone, and we know that time when all those will be ready. The concerns that the public health community has are, first of all, the resources match the opportunities. So we spend in the United States a lot of money on abstinence-only sex education, but we know it doesn't work, but we still spend it for ideological reasons. We fail to implement ideas that work. We fail to undertake multi-step approaches. This is what's considered the future of HIV prevention. You have behavioral change, biomedical strategies, everything together at once. You don't just do one thing at a time. So that's believed to be the future of HIV prevention. The big challenge now is like this. We've had great HIV treatment success. 22 antiretroviral agents, more than 2 million people are being treated. But there's 2.5 million new infections each year. There's no way we can ever win this battle, actually. So we need to marry HIV prevention and treatment. Right now, the only marriage of those two fields is in the mom-to-baby field, where the moms get treated and the babies don't get HIV. So we're trying to get all the treatment providers in the world to understand their prevention opportunities. It's estimated from this model by Solomon, if you do that, if you combine treatment and prevention, you will avert 30 million infections over 5 years, and you'll avert 10 million deaths. So the work at UNC, and I didn't tell you, like there's at least 100 people working on this stuff, and I'm not going to give every person credit. There's a lot of the faculty have worked for 20 years on all this stuff and made real big contributions. I think I would say that UNC has been kind of dead center in the treatment and prevention fields and made big contributions, and we think it's a vibrant field and we'll continue to work on it. The other thing I need to end with is like globalization. So UNC is now in the process of globalization, and while most people here work domestically, the university is committed to working in India, China, Central America, and Sub-Saharan Africa. The reason globalization is important is because those are opportunities for service, research, and teaching to be all ignited and fulfilled in a variety of ways. The most important thing for us here is that to be competitive in research, we really need to work in a worldwide scope. You can't really be competitive if you're only working domestically. Ben Calvo, the oncologic surgeon, is trying to do intraoperative radiation for tumors, but he can't get enough patients here as he could do in China and UNC. So he's on his way to China to talk about a collaborative study with intraoperative radiation. So instead of getting 10 doses of radiation after your operation, you get 1 dose during your operation. For HIV research, we could never have done our work without Malawi. And so I'm going to end on Malawi, which is just an example of why you work globally. 12 million people, very poor, very low life expectancy because of HIV, life expectancy 39, 2 physicians per 100,000. So this has been a place we've worked for 20 years. This is the building where we do the research that led to a lot of the conclusions of the talk I gave. This is the laboratory that's so critical because this laboratory is a state-of-the-art laboratory that lets us collect specimens, process them, and do a lot of things that would otherwise be impossible. This is the library that was built as a medical education facility for re-entry into the country of people we train. This is the UNC homepage as the Malawi library. So the librarians here went there, built a library, and made it a virtual UNC healthcare library. So the globalization as it relates to infectious diseases and as it relates to HIV prevention is absolutely critical. So thank you for listening. That's all I have to say. And as I said, if only Bill Grossman would be here, we'd know something worthwhile. We'd know, questions or comments. Any comments or questions? Ada, do you want to say anything about domestic HIV? Ada was the person, raise your hand, Ada. If anybody doesn't know, Ada Adamora, the Tar Heel of the week. But she's now become the Tar Heel of the month, I heard. They're gonna rerun the story. Comments or questions about this? Yeah.
About 10 years, maybe long ago, they were trying to look at people who didn't seem to get it right. Magic Johnson didn't get
Progress.
it too quickly.
Yeah.
Did that just
No, there's two different things that have gone on. One is the field of exposed uninfected people. Now, suppose there was a group of people who really were exposed and uninfected. Those would be really important. Well, there was one guy who kept having anal intercourse and never got HIV in New York City. He kept going back to the doctor saying, I'm really special, but no one really paid attention to him. And after about 10 years of complaining that it didn't matter what he did, he never got HIV, it was recognized that that guy was deficient in the CCR5 receptor. And that guy's CCR5 deficiency led to the realization that R5 virus is transmitted across the CCR5 receptor, and without CCR5 receptors, you're not immune, but it's much more difficult to become infected. People of color are unlikely to have that deficiency, so they're at a disadvantage because they always have the intact CCR5 receptor. There were some sex workers, CSWs, but that's not a good abbreviation because that also means clinical social worker. So so CSW is very offensive when you use it, but commercial, and so we got rid of the C, SW, sex workers. So the sex workers in Africa, in the Pumani district of Kenya, that a guy named Plummer has been studying for a long time, and he claims that these sex workers don't get HIV infected. But basically, no one's ever been able to reproduce anything he's ever done. It's a very simple statement, okay? If this population really had some mystical protection, I believe we would have been able to make a vaccine a long time ago. And I have very little faith that that population leads to discoveries. That's the second point. The third point you raised is, are there people who don't progress very quickly? And the answer is yes. There are two big, CHAVI has had the money to do genetics. And so it's interesting, the CHAVI is supervised by 4 Nobel Prize winners and some other people. And so at the first CHAVI meeting, it was like these Nobel Prize winners, a hypothesis was given to them saying, here's genes we'd like to study in terms of disease progression. Who progresses fast, who progresses slow? And they said, we don't want your hypothesis. We gave you like $300 million. Just measure every gene and come back in a year and tell us like there's 33,000 SNPs. Tell us about the 33,000 SNPs in all these people. So these guys went ahead and did this. They measured, so they did genome-wide association in 600 people in Europe, 33,000 SNPs. And what they showed was, and confirmed one thing, that an HLA-B gene controls progression, HLA-C gene controls progression, and there's a third gene called KIR that helps control progression. So those genes, how do they control progression? That's intensively being studied now. So some people genetically don't progress very fast. That's the third point. Fourth point. Some people get complete suppression of the virus. Those are called elite controllers, and we don't understand how that happens at all. It's a long-winded answer. Fred.
Mike, can you make any comments on happy, hopeful observations coming out of CHAVI regarding neutralizing antibodies?
Yeah, okay. So I think, well, I can give good news and bad news. Okay, I can say that the good news is people make neutralizing antibodies. There are neutralizing antibodies. They exist. There are 5 monoclonal antibodies that neutralize. And there was going to be a study, and those monoclonal antibodies, they were discovered and they can neutralize, and if you give an animal a huge amount of those antibodies, they won't get HIV, like grams of the antibodies. The problem is those antibodies look like they're autoimmune antibodies. The good news is you get neutralized. The bad news is you get lupus. That's not good. So there's a real trying to understand about the formation of those neutralizing antibodies. Second, 10% of most AIDS patients form broadly neutralizing antibodies late in their course, but they don't work to neutralize their own virus. Among that universe of AIDS patients, some of them form very broadly neutralizing antibodies that might work through unique mechanisms. And so there's a real search going on. We in CHAVI plus the IAVI, another group, are searching for broadly neutralizing antibodies that work uniquely that could lead to a vaccine. The problem we're going to have...
Not cross-reactive with...
not lupus, right, not lupus, but the problem we have is even if we make such a vaccine, we don't know how we'd ever get anamnestic responses quick enough so you'd have enough antibody in your mucosa to prevent you from getting infected. So we have, and I said, the vaccine thing, I said, we ought to give $10 million to the search for extraterrestrial life. And should there, 10 million is a small amount. Give them SETI, remember like that movie where they're searching with these big telescopes, and if we find that there are people in outer space, they can come and help us make an HIV vaccine. If they could get here, and then about a week after I suggested this, kind of facetiously, there was a headline that there were flying saucers over London. So, I mean, some other species probably knows how to do this, but not the Homo sapiens. So those are two big challenges. Other comments or questions? Yes.
CCR5 distribute, lack of CCR5 distribute.
It's not lack, it's a deletion. You always have CCR5, it's just delete.
Related to bubonic plague, is that right?
No, there's a lot of CCR5 hypotheses that have not been born to fruition. You know, why would a Homo sapien have a CCR5 deletion? Did it in fact contribute to survival during plague? How would you prove that? I mean, it's a very interesting hypothesis. Just very hard to the whole field. And there's a couple of papers that don't confirm. They agree with that hypothesis. It's very hard to confirm that that's the reason for the deletion. Very genetically difficult. The other thing about CCR5, there's a huge fight. If you want to get into the details of fighting in biomedical science, there's a guy named Ahuja at San Antonio who's written a whole bunch of papers about the chemokine levels and the CCR5. And he says when your chemokine levels are high, they bind the CCR5 receptor, and you don't progress disease, and you don't get disease, and so on and so forth. The CHAVI people have not been able to confirm any of his findings, and these are in Science and Nature and places like that. So the fight that's brewing between Ahuja and the rest of the world is very great. So it's going to be exciting to watch as it plays out in the next few months.
So what is the function of CCR5 other than to give us AIDS?
Well, you raise a really good point. You're allowed to have a deletion in CCR5 and be healthy. On the other hand, CCR5 is a really important molecule in host defenses. And when they made Maraviroc, the big fear about Maraviroc is they don't want to use it real broadly because they're really afraid of what the hell is going to happen. Now, in the early Maraviroc literature, there's a concern that tumors, non-Hodgkin's lymphomas, were developing in these Maraviroc patients. It's not been borne out. But there is a real challenge to the host. When you give Maraviroc over 3, 4, 5 years, we're going to learn, is there a problem? Until then, we're not going to know. And furthermore, Maraviroc probably doesn't completely block all the receptors, you know. I mean, so you've asked a really key question. CCR5 is not there for luck. It's really an important molecule, but you're allowed not to have it. You're allowed to have a deletion in it and still be healthy. Other comments or questions? Thank you all for listening so long. Thank you.